Hello and welcome, everyone. I am Jasmine Arazi, Program Manager here at IPFCC, and today I'm joined by my colleague Marie Abraham, Vice President of Programming and Publications, and Pam Dardis, our Vice President of Strategic Initiatives and Operations. Providing technical support is our colleague Matt De Silva, and today's discussion is on how to establish and sustain effective patient and family advisory councils. We are very excited to see how many of you are here, and it's obviously a topic of significant interest. Please feel free to chat in your name, organization, and where you are located. We are recording this conversation so that we may share with those that are registered for the recording and also post it on our website. While we like seeing faces, if you prefer, you may go off camera. Next slide, please. We want to acknowledge our PFCC Connect sponsors. A special thank you to Emory Healthcare, Providence Healthcare, and University Health. Thank you for your continued support. Next slide, please. As you all know, our conversations are intended to be interactive and informative. We will start with a few slides to set context and to provide information and get the conversation started, but then we will dive right into discussion. We just want to remind everyone of our group agreements. That is, be as present as possible. When we move into discussion, it'd be great if you could go on video. Participate actively. We encourage all of you to be curious, ask questions, also share your perspectives or any experiences and challenges you have faced. You can do so by either chatting that in or raising your hand and waiting to be called on. Let's share this space. Let's allow others to contribute to the conversation as well. And we also ask that you embrace a learning and growth mindset. All of you bring great expertise, and we have a lot to learn from each other. And finally, we hope you enjoy this discussion and have fun. If at any moment you experience technical issues, you may chat directly with Matt De Silva. And I will now turn it over to Marie.
Next slide, Matt. Thanks. So thank you to all of you, all of the registrants, for sharing questions as well as ideas for this topic in the registration process. And here are some of the issues that we heard about, what you are most interested in today. These are select. They are not everything that was written into the registration application, but the need the need for planning, structure, implementation strategies, and ensuring that there's a feedback loop for the PFACs to find out about what the impact that they've had on the organization. What are practice-based strategies that support PFACs and help with sustainability? And information from other small rural northern hospitals on times, staffing, resources required for best practice. And I think that's something that is very interesting to hear about, since we do have a large group, and we hope we can hear from organizations that aren't large health systems. The need, how can we improve diversity and representation in our PFACs? So that's a question that keeps coming up. Coordinating structures when there are more than 10 PFACs. So when there are multiple PFACs, how do others create those coordinating structures? And then how have others been successful in establishing and maintaining specialty councils? So those are some of the things that we heard, not all of it, as I said. I'm very, very pleased. It's my great pleasure to hand off to my colleague, Pam Dardis, who brings incredible expertise to this topic, as do all of you. So Pam.
As Marie and Jasmine mentioned, I'm going to just provide a little bit of context and foundation for our conversation today by sharing with you some key learnings about strengthening partnerships with patients and families. These learnings were developed from an online survey that we conducted of children's hospitals in 2020 and 2021. I think actually I recognize familiar faces and names on this call, so some of you participated in this survey. We asked about PFACs and partnerships with patient and family advisors at children's hospitals and also conducted interviews with individuals representing PFACs at different hospitals. We synthesized the learnings from this project into what we call 10 key learnings for strengthening partnerships with patients and families. Matt, next slide, please. So the first key learning is the importance of leadership, having leaders who talk the talk and walk the walk and who are visibly demonstrating their support for and commitment to patient and family-centered care. Leaders, I think, as we all know, have an important role to play in terms of dedicating resources and making sure that partnerships with patients and families are part of the organization's mission and vision and the ways in which they do their work. The second key learning is that successful PFACs develop and expand progressively over time. This is sustained work, and there is growth and maturation over time. There's also sometimes ebbs and flows. So sometimes things move backward a little bit, but the ultimate goal is that it's continuing to move forward. One of the really important factors that we saw in this development and growth is sustained attention to relationship and trust building within and outside of the organization with patients, families, and communities. Next slide, please. So the third key learning is that having a defined infrastructure facilitates and sustains PFAC development. And what we mean by having a defined infrastructure is that there's an allocated budget, there's staff coordination in the form of a staff liaison or somebody who has responsibility for facilitating the work of the PFAC, and making sure that on a day-to-day basis, the PFAC is moving forward with a structure in place to support the work, that it has a place in the organizational chart to make sure that the work of advisors is heard, listened to, and acted on. The fourth key learning is that organizations need a specific recruitment strategy to sustain and expand membership and ensure representativeness. I think, as we all know, recruitment is not a one and done, but it's something that it's ongoing and revisited over time to make sure that we are reaching the people that we need to reach. In addition, as part of that recruitment strategy, it is helpful to have a dedicated and concerted focus on ensuring that you're recruiting patient and family advisors who are reflective and representative of the population that the hospital is serving. Next slide. The fifth key learning relates to expanding involvement of patient and family advisors beyond the PFAC. This can be a way of reflecting growth and organizational commitment to partnerships with patients and families. So many hospitals, for example, have organizational work groups, committees that work on different issues within the hospital. So thinking about ways in which patients and families can also participate on those types of committees and work groups. So thinking about quality and safety, patient experience, patient and family education committees. This provides another way to ensure that patient and family voices and perspectives are really integrated throughout the work. The sixth lesson is that investing in onboarding, mentoring, continuing education, and training supports patient and family advisor participation over time. Well, we always say that the expertise that you need to be a patient and family advisor is based on your lived experiences. It's also very helpful to be prepared for the role. So things like thinking about a formal orientation for new PFAC members, an onboarding process that supports them in understanding the work of a patient and family advisor and provides them with the supports that they need to participate. It's also thinking about opportunities for ongoing education, so making sure that there's mutual support and an opportunity for patients and families to grow their skills as well. Next slide. The seventh key learning is that as the number of PFACs grow, it's helpful to have mechanisms to ensure coordination and synergy of effort. So over time, there are many hospitals that, as their patient and family advisor program grows, decide to set up a structure that includes multiple councils. So you may have specialty councils like a youth advisory council, condition or disease specific advisory councils. There are hospitals that have other types of councils like gender proud or LGBTQ plus specialty advisory councils, Spanish speaking advisory councils. So it's important to make sure that there's a mechanism that brings all of these advisory councils together so that they are not siloed and separate, but really supporting the work of the organization and working towards one goal. So it may include having a larger coordinating council or a periodic meeting of council chairs where you can make sure that the work of these councils is coming together. The eighth key learning is that successful PFACs adapt to and are very involved in organizational decision-making about emerging issues. I will say this was particularly relevant at the time that we did the survey of children's hospitals. So that was at the end of 2020, during the COVID-19 pandemic. We observed that hospitals that were best positioned to transition during the time of COVID and continue partnerships with patients and families were ones that were already positioned to evolve patient and family advisors in emerging issues, and they were therefore able to pivot and ensure the continuing voice of patients and families. In some cases, that looked like providing their patient and family advisors with information and support throughout the pandemic, and then getting their perspectives and opinions as hospitals grappled with some key issues related to family presence, and other ways to continue partnerships during COVID. Next slide. The ninth lesson is that measurement, evaluation, and reporting of PFAC impact is important to make sure that people within the organization and outside of the organization understand the role and the impact of the PFAC. So measurement and evaluation is unfortunately something that's considered an afterthought oftentimes, but it's helpful to kind of bake this into the work of the PFAC, so being able to capture their work and impact along the way. And then I think the final learning is very obvious in today's world related to the use of technology. For this key learning, I'd encourage us to think about it a little bit more broadly in terms of how we can revisit PFAC processes and practices to open up participation. A benefit of COVID-19 was that virtual council meetings were easier for some people to attend, and we heard that it helped some hospitals improve the diversity and representativeness of their councils. So as we look forward, what other options and supports can we put in place that meet the needs of patients and families and make participation easier, particularly for a diverse group of patients and families? So I will stop there. I know that's a lot of information, and turn it back over to Marie and Jasmine for the conversation. Looking forward to hearing from and learning from all of you.
Yes, thank you, Pam. That was great. And so we don't want to lead or guide this conversation. We want you all to do that. So if people would like to start speaking up about successes that they've had, or also challenges that you've experienced. And Matt, you can take down the time for discussion slide. Great, thank you. Okay. Emily, did you want to say something?
Yes. First of all, I agree with all the points you made about what's essential for PFACs to be successful. And my experience, both as a former patient participant and an employee for a while, is that it's really challenging in these times to provide the full resources that are needed to run PFACs. In my experience, councils themselves are resource intensive, time intensive for employees to support them. And there are otherwise, when I was still working there, we started doing things like listening sessions where it took less time for the staff. It was a quick way to get good information, but also you couldn't go as deep as you could with meeting people month after month in a PFAC. So I'm wondering what thoughts other people have on what organizations are going to do to meet these resource need issues, or if they have a different view of it.
Yeah, thanks, Emily. A good question, because that right now after COVID, I think that's even more important. I see Anne Marie has your hand up.
Yes, thank you. I have two comments, please. First of all, I want to say kudos to this organization for putting such masterful design to this. Incorporating many different organizations gives a lot of feedback for improvement in having councils. I am a layperson, a patient exclusively, and I am on a member of a local hospitals council. And I am a type 1 diabetic advocate, and I have been silenced and refused space for commentary on improvements that are required and necessary for this particular hospital. So my second comment is, because I'm a type 1 advocate, but I'm an advocate for all diabetics, that I plead with you to please don't shush diabetics from your councils. And we have important, incredible information that can save you time, save your staff from quitting, all kinds of things. But please, if you want to separate us out and start a specialty group for diabetics, with the quantities of people becoming diabetic more and more, the surge, I think it's vital. And there's problems across the country where I know many diabetics can help improve your systems. Thank you very much.
Thank you, Anne Marie. And I think that's an important point. And I think that's part of what Pam was talking about when she talked about trust building and relationship building. So if you feel like you're not getting listened to, or your concerns are not being acted upon, I think that's really important. And it's not only diabetics, it's probably a lot of other groups.
Yes.
Darnis, it's so good to see you.
Yes, it's great to see you as well. My name is Darnis Jackson. I'm an administrative manager at the University of Michigan in the Office of Patient Experience, and my team leads our patient family advisory councils. And so we have quite a few councils, about over 30 right now. And one of the things that we end up doing that has been pretty successful since we started it is we started what we call a PFAC leads meeting, where we have a quarterly meeting with all of the leads from each of the patient family advisory councils, and everybody can attend at the time. We try to mix it up at the times that we have it, sometimes in the evening, sometimes during the day. Obviously, some of the leads of some of those committees are top like leadership, and so they may be not free during that time, but we also record them so that if someone can attend, then we could just send it out to them by email and they can hear everything that happened. But one of the things that's helped to do is help for collaboration across the system, because some of our PFACs are in certain centers at our system and maybe doing something that is useful to our other centers, or may have opportunity where we can collaborate across the board between them. And then during that, we have agendas set each time where we identify one of our patient family advisory councils that can talk about a lot of the great things that they're doing. So we always highlight one of the patient family advisory councils. We always have an area where we talk about issues and problems. And so we identify, if we're having a problem with recruitment, we'll have, this meeting, we'll talk about the problems we're having with recruitment and how to help. Or if we're having a problem with engaging our advisors, we'll talk about that. And then we also just keep a little time at the end for like questions. And so it's been very useful for us, because it kind of helped us to kind of build the community so that we can know what's going, because of being so many, it just helps us to keep everything in order. Outside of that, I think it's really important for the patient family advisory councils to always have a person specific to the clinic area or center that patient family advisory council is in, but also have a patient lead that can help as well and lead. And so I think that helps with, as you're thinking about, I think Emily, I think was speaking towards how to work during this time. For one, having multiple people that's leading the committee, it helps so that if somebody leaves, you can have somebody to be able to kind of replace them and keep things still going. As well as with the pandemic, we went virtual. And so a lot of people want to come back on site, but we've also still kind of kept that virtual aspect as well. So people can log in if they're at home, if they, even if they're driving in their car, they can log in and listen, even if they can't see it. And so I think those are definitely opportunities to help keep it going. And so
that's terrific. You just answered a lot of questions about what do you do when you have more than 10 PFACs, and what's the structure and how do you do that? How often do your lead PFACs meet?
Yeah, so we meet quarterly, and so we don't want to do like monthly or something like that, because one, we want to make sure we have enough information to cover, and then also, like I said, a lot of those leads are, could be like the CNO and stuff that may be helping to lead it, and so we don't want to kind of take up too much of their time, but we know that it's still a very important aspect to have that patient involvement, with the system. So.
Thank you. Moon, thanks for waiting.
Hello, everyone. So my name is Munja. I'm located in Alberta, Calgary, Alberta, Canada, and my network interprovincially, Ontario too. So as a patient partner, I'm a first-generation immigrant from South Korea, and obviously language barrier to engage this kind of patient caregivers council connection, because we are always kind of last one to connect it, engaging, or sometimes I've been through a lot of research, medical research. They not really patient caregivers centered research. They more focus, specialist focus. So finally, lately, Health Canada grant focus and patient partner centered research grant is more emphasized. So I really appreciate this kind of movement that I can see in my life, my late lifetime. And what works, and during the pandemic in Ontario, especially, CD, Toronto's public, the health public, they organized a community health ambassador, over 700 ambassadors, which based on the 39 needed area, that means a low income, whatever diversity population located, they organize, select who is a resident leader in that particular area. So they recruit all that across the GTA, over 600 people, 3.5 years of a pandemic. They work so well because mostly English second language people as a first generation comer, they don't trust you immediately, especially medical help. Or who you are, I have to know you, how you can find me, how did you find me? So suspicious is always blocking. But there's your community, who is your resident leader, who not really academic background, but the neighborhood engagement person, you earn trust right there. So through the community health information fair in person, very limited space, even during the pandemic, we did that. People just come in, say, oh, I know you, I can ask you, you refer doctor, or whatever. It's a conversation continue on. So that through that experience, I could ask all over these platform people who is leaders of this advocates, and we need training, orientation, what we into it as a patient or patient partners or patient caregivers, whatever role, without the academic background or medical. So give us orientation of a little simple PPT slide, few of them. We catch it very well. Without a paragraph and lengthy English, we're not going to get it. We might lose it, totally lost, if your presentation is verbally only. So just eye-catching few slides, give us a training periodically. During the 3 years of pandemic in Toronto, once a month, there is a doctors led us a training, what's up to date, which not really engage the diverse population area to get the vaccine, even who are the anti-vax community, pseudo-face community. So these are kind of little hidden, but very important as a first language and not English community. On behalf of that, also I'm on behalf of 55+ senior groups in Calgary and Ontario. So we are the needed there, very basic need, but we are here to important medical research connection. Thank you so much.
Thank you, Munja. Rhonda, thanks for being patient.
Oh, no problem. So I have lots of things, but the first thing I want to respond to, Vicki from Hopkins posted something. I was going to reply. So first and foremost, at our institution, we initiated a family engagement and research program within the research department to get patient and family advisors as part of our research design teams, research implementation teams. And it took a lot of work. We learned a lot. But the most important things we learned is not only is training needed for our patient and family advisors, but for our staff, both the researchers and clinicians, because this is new. They really don't know how to work in partnership with patient family advisors. And Anne Marie, my heart just went out to you because I have seen that so many times. And it's just plain disrespectful. But again, you have to build that trust and authenticity. We have a person she is the parent of a child with medical complexity whose job is to recruit and onboard both advisors, family advisors, and also clinicians and research staff, and make sure that they're trained. And she facilitates the initial meetings so that the group gets off on the right foot, so they understand how to talk to each other and that it's a safe space. And lastly, we pay our advisors. We do not expect this to be volunteer work. And I think organizationally, on our clinical side, there are some PFACs where it's still assumed that they're volunteers. And then that leads to a very unrepresentative group. Thanks.
Oh, thank you. I'm going to say your name wrong, I'm sure. Bethana?
No, you did it. That's
Oh.
great.
And then I'm going to, I see a good question in the chat, so I'm going to ask that. And then Emily, I'll go to you. Yes.
Yeah. I'm working in the Yukon and the North in Canada at a pretty rural hospital. We are just beginning our patient engagement framework and strategy, and our goal is to have a patient and family advisory group. But something that would be really helpful if the group could share insights on, for me, would be just very concrete logistics. How many staff does it take to oversee an advisory council? And with that, how many meetings can they facilitate? How much onboarding, how much time? Is it one full-time position people have found successful, or is it 2 full-time positions, or 1.5, but you can only meet this many times a year? That kind of information would be extremely helpful for me right now, if anyone had that.
Great. Does anyone have ideas to help Bethana?
Did you want us to raise our hand or just speak?
You can just speak if you want. Darnissus, do you have a good idea?
Yeah, so I mean, I could speak to the staff component of it. So for one, I mean, to me, you need at least 2 people that are helping to run it. We honestly do not have, out of all of the 30 PFACs that we have, a person that is specifically only running the PFAC. All of our staff individuals that are running the PFACs are either in social work or they have a full-time job that they're doing. So this is on additional to their job that they're doing. So which it definitely brings some complexities, because your primary job that you're getting paid for each day comes primary, right? So I think, but I do feel that our PFACs that are running the most successful have at least 2 people that are able to coordinate what's going on, especially when you're talking about when people need to step out. And for some of those, the 2 people includes one of my staff or one of the staff from our office and staff specific to the center. Well, you had another question, I think, that I was trying to answer. it was around I think it's training you said, or
Mhm.
yeah. So as far as the training, we all of our volunteers go through a full training before they're even placed on a patient family advisory council, and that the same the training that they go through is the same training that staff and faculty would go through for our system. So they go over code of conduct, go over confidentiality, all of the same things that our staff and faculty would go through. That's what our volunteers go through. So like any information that's privy to them or that's shared with them, is told to kind of keep it in house and so that they can work on it effectively. And then I think those were the two that I wanted to answer from what you were saying.
Great, thank you very much. I want to just bring to the forefront, is it Jennifer's question about fathers? Because I know that's an issue in working with international newborn intensive care collaborative. We don't have very many fathers who are in that, but we do have fathers. But I saw that now I have to scroll back up in our I saw that we had an answer to that question from, oh my goodness, let me see, Vicky. Vicky, do you think you could come on and just share a little bit about how you did that recruitment of fathers?
Sure. I was really direct with everybody. I just was like, everybody, we need dads. We need dads. It's not, and I was kind of like a little bit of guilt, everybody. I was like, it's not okay. We don't have dads. It's not okay. So I didn't say it just like that, but I did like a huge organizational at the Children's Hospital that I work in, UVM Children's Hospital. Basically, we need dads. Help me get dads. This is why it's important to have dads. Because I know that people who aren't thinking about advisors aren't thinking about advisors, aren't thinking about recruitment the way we all are, like all the time, in this space. And then the other thing I wrote in there was community partnerships. Is I realized the community organizations who are doing dad groups, I have a direct connection with all of them. And so much so that in 2 weeks, I'm meeting with a group called the Dad Guild, which isn't that fantastic? The Dad Guild.
Yep.
So I think community partners are just a really important. The other thing is I have another community partner that has a distribution list with thousands of families. And so they put that out as well. And it was dad specific. Because as you know, I do get a lot of females or moms who are like, oh, this sounds great. And I really did frame it as looking for dads. And that seemed to help a little bit. That being said, I will tell you, we got 4 for my PFAC, which is the PFAC isn't that big. It's about 16 people. I had 4 dads. 2 of them are no longer there. So I'm ready to recruit my dads again. So I'm ready to relaunch just like this month.
Great. Perfect to focus in on the dads. I think they're so important, or partners, just partners in general. Emily, I'm going to skip over you just to go to, because we've got so many hands up, but I'll come back to you at some point. Laura, can you jump in?
Some great conversation. I work in a large health authority with over 12 hospitals, and I support 10 PFACs in our health authority. And some of the successes that we've had are definitely aligned with Pam's great summary, and I've read that article. It's wonderful. Certainly to begin with that trust building for recruitment, the people that express interest, we do meet with people one-to-one and to start develop that relationship from the very beginning. And as I'm a support across the large health authority, I always make sure that someone that represents the area that PFAC is going to represent is included in those one-to-one recruitments, or I guess sort of meet and greets. I also support and host PFAC agenda planning meetings with each PFAC. So I'm there to consistently support people as they're planning their meetings. I also promote creating regular engagement trackings and presenting that to the PFAC, because I think members sometimes don't recognize the impact that they're having. And so regularly connecting back with them and saying, this is all the great input that you've provided, and these are the things that have happened because of your input, can be really motivating for people to continue their work in the PFAC. We also with agendas, we also include a presenter summary if presenters are coming to present at the PFACs to help people think ahead of time about the topic that's going to be presented and get them their thoughts going prior to the meetings. And then we do host orientations to all new members. Because of the orientations, we do, instead of doing random recruitments, we will do recruitments like twice a year for the PFAC so that we can orientate the group together, and then that will also help with relationship building too during those orientations. Some of the challenges that I'll share are that changing leadership. We have leadership changes all the time, and so to get them to get the PFACs to be sustained and grow, that can be challenging when leaders are constantly changing. Also, some leadership don't take the support that I offer, which I always find surprising, but I guess they want to do their own thing. So then that way there is some challenges there with them not sort of the meetings may be going off the path of what a PFAC should be doing, which in Fraser Health, we feel that PFACs are a way to advance person-centered care as a whole. And I know that's very general, but that's the overarching purpose of our PFACs. And then some of the gaps that we're looking to fill more recently is to diversify our representation on PFACs. And people have mentioned that already, as well as evaluation, which is well known throughout the literature. But to answer Emily's question around how to support PFACs, what can promote PFACs is in our area. I live in Canada, so we are accredited regularly, which I think most places are. And so for us, Accreditation Canada very much supports PFACs, and that's something that we use to promote the growth of PFACs.
Yeah. Thanks for bringing highlighting the need for leadership support, and especially for sustainability, because that was a huge issue over the last several years, is that leadership changes, and then how do you make the case that this is important and don't drop us out? Yeah. Okay. Paula.
Sorry about that. That was my phone.
Oh, that's okay.
Yeah, I'm in just one hospital, but we have two councils because it's a mental health care facility, and the Patients Council and Family Advisory Council were asked to join together, and we said no, we didn't want to join. And we lost one of our facilitators, and it has not been good for our councils. The one person who's working is working too hard. So one of the major things that you have to do is, have enough staff, invest in the time, invest in the money, so that you can engage people in the work. I'm on a lot of committees, and I'm very happy to give feedback, but I also need to know all the information. And one of the committees I'm on, there is just too much information that I do not have access to. So when you are planning for the future, access to the information is also vital. We during the pandemic, we went to a lot of virtual meetings, and that included the committees, which was great because I wouldn't be able to be on as many committees that I am on without being able to join virtually. So that's something that you really want to think of. Another key thing is that I took courses on communication. For me, it was crucial conversation. But I really agree with the one fellow in that not only and the one who's talking about researching is that staff need as much education as people on the councils, and you have to have a really strong candidate if you're going to have a staff member helping with the councils. Someone like a social worker or who's strong in rehabilitation, those kinds of ideas. And and that recovery is in the eye of the beholder. You know, we do struggle at times because, you know, we are not listened to. And that one of the major things that just happened recently is we did lose one of our facilitators, and that has really been, you know, people have been thinking about quitting and stuff like that. So you got to really think of the impact of that, because the one facilitator, we have so many ideas. She just doesn't have time to do everything and do major projects like we used to do. We had a resource fair in the past, and the idea of her doing it again is just not probable at this point. And we are pushing to have someone be hired again, in going towards what the organization wants, because they're just not budging. And that is a very, very difficult situation. So anyone who's starting out new, think of all these things.
Yeah.
And it's engaging people who are lay people. You really have to take the time to make them understand some of the concepts and the verbiage and everything else, and the background history. So that's one of the major pieces.
Yes,
because not everybody's going to be able to be into the swing of things immediately.
Yeah, thank you, Paula. Okay, oh my gosh, we have lots of hands up again. Deborah.
Hi, my name's Debbie Kersey. I am an experienced advisor at Jersey Shore University Medical Center. We are in the Hackensack Meridian Health Network in New Jersey. I guess you could say that I facilitate our Patient Family Advisory Council. So responsibility for the PFAC falls under my department, and which is patient experience. And along with my director, we are, you know, in charge of the activities of the PFAC. And then, you know, we did do training, but we have different levels of participation. So we have people who only, you know, who don't want to come into the hospital, who either don't or can't come into the hospital due to family responsibilities or, you know, some medical issues. So, so we have different levels, and that I think helps to sustain our membership, because it's not a barrier. You don't have to be here. So with these different levels of participation, everyone has to sign a confidentiality agreement. You know, everyone has to agree to, you know, abide by the rules just as an employee would here. But because we have the different levels, I think it helps us. We struggle to try to get a little bit more diversity. We are, you know, somewhat diverse, but we are not completely representative of our demographics, and we struggle. So, you know, we will just keep trying to do that. We work with our family health center. We work with local clergy to see if they can perhaps help out. We work with our DEI department. And so we do, you know, we do try to replicate our diverse population, but it seems to work for us.
Great, thank you. Thank you, Deborah. In the interest of time, I'm just going to keep moving on with the hands. And you got a thumbs up there. Okay, Michelle, so good to see you.
Hi, great to be here. So good to be here. So the system that I worked in, we had the luxury of having Bev come in the very beginning and talk to our administration, and that's how we got the first director of Patient Family Center Care. That position was held all the way till 2018. And having a director of patient and family centered care that oversees whether there's other councils at the other hospital systems or the different clinics or whatever you may have, but having that one person that overarches, does the training, maintains the stipends, and make sure that everything is working seemed to be the glue that held everything together. We had committees that ranged from our youth advisory council was extremely active. We had a behavioral health committee. We ended up having a pediatric to adult transition committee, which was one of my huge passions. Sickle cell, cardiac. I saw in some of the comments you asked, how do you measure it? You have advisors coming to discharge meetings. We had our cardiac unit had discharge meetings that the meetings were run by the advisors, and they were there as past patients, and our readmission rates dropped so low. So yeah, that's a great way to measure, how that went and what impact it had. But having somebody that is overarching those councils, I felt was key. Having nurses, social workers also involved, but they have to do their patient work. And so to divide their time is very hard. And then that's when there started to be drift. And so I'm going to advocate and say, you guys got to have patient and director, and you got to have a budget. You have to have a budget. There's got to be a line item. And as Bev always said, the PFAC has to be on the organizational chart. If they're not, then your hospital systems are not taking them as serious.
Yep. Thanks. You just hit on a number of points that we learned in one of our New York studies on PFACs. You have to be in the organizational structure and have a direct line to the leadership. And also, now I forgot the second thing. So I'm going to move on to Kim. Oh, no, Kathleen, you're first. I'm sorry.
Good afternoon. I'm from South Coast Health, which is a 3-hospital system in Fall River, Massachusetts. And some will know this, in Massachusetts, we have a state law that requires every hospital to have at least one PFAC. One of the things, beyond all the good things that we've heard, that we do is we have staff members as well as PFAC members united on our meetings. The medical director, the department director for our physician group sits on the meetings, so that if we bring questions relating to situations we've experienced or others have told us, we get immediate responses. We're under the patient experience department, as I noted from my colleague from New Jersey. And that has worked beautifully for us. But we report to the hospital board twice a year. They get all the minutes of our meetings. Of course, by state law, we must give statistics and annual reports to the state. But I think one of the best things for us to get credence is that we actually have the CIO. He'll come to our meetings. We have a lot of the C-suite that attend our meetings to see what's happening, and also we can call them if we have a concern. So I think that helps build your place in that hospital structure. Thanks.
Thank you. Thank you. I remembered the second one. It was the budget. You need to have a budget. You need to show that, you need to show the leadership, make the case, make the business case for doing it. Okay, we are getting close to time. So Kim.
Hello, can you hear me?
Yes.
Okay, great. Yes, thanks. Yeah, I got on this call. A colleague of mine told me about it. So thank you so much for having it. I am the hospital relations manager or patient advocate in a medium-sized community hospital up in Western New York in the Buffalo area. And I've been in this role since January, and I have been asked to get a PFAC going. They have been trying for a few years now to get one going, but there's been changes in staffing and all that. So anyway, so I'm really just looking for some advice on what are the first steps. I mean, other than I've got sticky notes in my PFAC folder of patients and families that I've met that I thought, oh, they would be great. I've got about 8 of those. I'm just really looking for like first steps. I was directly reporting to the chief quality officer, and they actually were helping me start this earlier in the spring, but then there's been an interruption in that role, so we're waiting for a new one to be announced. But yeah, any advice or like what are the first steps? You know, I heard things like you have to have training and you know, all of this. So any feedback is much appreciated.
Sure. And I would say, Kim, we have on our website, we have a section just for patient and family advisory councils, and there's lots of good resources in there. And we're going to share some resources too. And, you know, Pam's got great expertise in this area. So there's a lot of stuff out there, so you don't have to recreate the wheel. And there's a lot of stuff in the chat. So we will be sharing the chat after this call. And does anybody else have any final thoughts before we, it's 12:55, so I want to probably be cognizant of time. Pam, do you have any final thoughts?
I do, yes. Oh, so many final thoughts. One of the things that I wanted to say is we will definitely look at the chat. I love the chat for all of these conversations. There are so many fantastic ideas that are raised. There are also questions that were raised that I know that we didn't have a chance to fully get to. So we will definitely look at those and think about our future PFCC Connect conversations and how we might be able to address those. We do make a transcript of the chat available, so you will be able to have access to all the rich information that is shared there. The other thing that I would say is if you are not a member of PFCC Connect already, it is free to join. We do have back recordings of our informal conversations available, so you can look at the different topics that were discussed and listen to those recordings, see the slides and chats. It also provides a place to ask the community questions. We have resources there as well, so I think that would be a great place to look in addition to our website and also making connections with all the great people here. The other thing that I wanted to mention is that toward the end of August, IPFCC will be opening up applications. This is for children's hospitals who would like to participate in a learning community about PFAC diversity, equity, and inclusion. There are some people on this call today, Vicki, Dejo, who are involved in this effort. We have funding from the Lucille Packard Foundation for Children's Health to develop a learning community. We will provide access to a toolkit of resources for hospitals. So if you are interested in being notified when the application is open, I'm going to drop my email in the chat. Please just send me a quick email and I'll be happy to make sure that you get information when we release that opportunity.
Thank you, Pam. So Matt, if you could bring back the slides, that would be great. So as you leave the conversation, just have this thought in mind or this question in mind. What strategies do you think would be most helpful to use for implementing the necessary structure and processes to support your PFACs? So just have that in your mind. I hope you learned a lot. I know I always learn so much from these conversations. Next slide, Matt. So I mentioned that we have resources, and here are some of our resources. At the bottom, you'll see that link to where we have on our website a special section just on patient and family advisory programs. But then the Pam's key learnings document resources in there as well. And we also have one on strengthening the diversity and role of patient and family advisory councils. And then Pam and others in a previous project, that this project that she just mentioned, they wrote an article and got published in the Patient Experience Journal on diversity and equity and inclusion in pediatric hospitals. So got that. Next slide. So many of you know your feedback is so important to us. We want to find out how we can improve. We want to find out what you found helpful. So there's a link, and Jasmine, can you put the link in the chat for us? And then you can use the QR code. We're just going to sit on this slide for 10, 15 more seconds. So in case anybody wants to scan that QR code. But we really do appreciate getting feedback, and we really act on it too. So, okay, next slide. So what's coming up? Well, the next informal conversation will be held in September. The date and the topic will be determined. We always run that way. And then recording slides and chat will be posted on PFCC Connect. And what we do with the chat, by the way, is clean it up so it's easy to read when we post it on the PFCC Connect site. And then if you have any resources, because I was not able to monitor that chat, it was just blowing up and I had to concentrate on what people were saying. But if you have resources, you please send them to us so we can share with others on PFCC Connect. And then, as Pam mentioned, continue this discussion in our free online learning community. So if you have any resources or links, you can certainly send them on to me. There's my email address in there. And I want to thank all of you for being with us today and staying in here and just sharing some good ideas and sharing some challenges. It was really helpful. So thank you.